Sepsis is defined as life-threatening organ dysfunction due to dysregulated host response to infection. It remains a major global cause of mortality, affecting millions annually. Early recognition is critical. Mortality increases with delay, especially in septic shock where time to treatment defines survival. Hospitals should implement structured sepsis screening programs with protocols, education, and performance tracking. Do not use QSOFA alone for screening. It is specific but not sensitive enough for early detection. Measure blood lactate in suspected sepsis. Levels above 2 millimoles per liter indicate high risk of shock. Sepsis and septic shock require immediate treatment without delay. Every hour matters in outcomes. Initial fluid resuscitation recommends 30 milliliters per kilogram of intravenous crystalloids within 3 hours. Further fluids must be guided by dynamic assessment like passive leg raise or stroke volume change, rather than static vital signs. Balanced crystalloids are preferred over normal saline. Hydroxyethyl starches are strongly avoided due to harm. Albumin may be added when large fluid volumes are required, but has no clear mortality benefit. Norepinephrine is the first-line vasopressor for septic shock. It restores mean arterial pressure effectively. Vasopressin can be added when norepinephrine requirements increase beyond moderate doses. Epinephrine is used in refractory shock, but increases lactate and metabolic demand. Avoid dopamine, except when norepinephrine is unavailable due to higher arrhythmia risk. Dobutamine is used in septic shock with cardiac dysfunction and persistent hypoperfusion after fluids. Source control is essential. Drain abscesses, remove infected devices, and correct surgical infections urgently. Start antibiotics immediately in septic shock within 1 hour. In non-shock sepsis within 3 hours if infection likely. Daily reassessment is essential. De-escalate antibiotics once cultures identify pathogen or infection is excluded. Short-course antibiotics of 5 to 7 days are often sufficient after adequate source control. Use prolonged infusion of beta-lactam antibiotics after loading dose to optimize pharmacodynamics. Oxygen targets in sepsis show no clear survival benefit between conservative and liberal strategies. High-flow nasal oxygen is preferred over non-invasive ventilation for hypoxemic respiratory failure in sepsis. Non-invasive ventilation must be used cautiously due to high failure rates and risk of delayed intubation. Use low tidal volume ventilation at 6 milliliters per kilogram predicted body weight in ARDS. Maintain plateau pressure below 30 centimeters of water to reduce ventilator-induced lung injury. Higher PEEP may improve oxygenation in moderate to severe ARDS, but must be carefully titrated. Prone ventilation for more than 12 hours daily improves survival in moderate to severe ARDS. Recruitment maneuvers may be used selectively, but aggressive incremental PEEP strategies should be avoided. Extracorporeal membrane oxygenation may be considered in refractory ARDS in specialized centers. Mean arterial pressure target is 65 millimeters of mercury for most septic shock patients on vasopressors. ICU admission should occur within 6 hours for patients with sepsis or septic shock requiring intensive care. Procalcitonin should not replace clinical judgment for starting antibiotics in suspected sepsis. Overall management requires early antibiotics, rapid hemodynamic stabilization, and continuous reassessment. Key takeaway is early recognition, immediate antibiotics, and goal-directed resuscitation improve survival in sepsis and septic shock.